It's a 20-minute talk. I'll try to do in 10. So everybody's familiar with the data set. I'm not going to go through it, but this was the data set. At 1 year, 28 studies, you can see there was no difference in death in the Kitsanos analysis. It was a well-selected group of patients and studies. At 2 years now, with 12 studies remaining not out of the original 28, there started to be what was considered to be a signal and a hazard ratio which approached significance now, not crossing the line of identity. And at 5 years, with 3 out of the original 28 studies, there was a hazard ratio also statistically significant in showing a potential for paclitaxel death. There was also a construct that showed that paclitaxel dosing, according to the authors, led to more dosing led to more death. That was done because it was a proof of concept. It's one thing to show an association, but to show causation, you have to show some dose responsiveness, and that's why they went to this modeling. The modeling I will show you is problematic. So unfortunately, I think the exclamatory title probably didn't belie the strength of this analysis. It says the increased risk of death following application of paclitaxel balloons and stents. There is an increased risk, and further investigations are urgently warranted. Let's talk about how good this data set was. It is summary level data, it's not patient level data, so all they could do is take the numbers arithmetically from the papers that were in the literature and use them mathematically to look at an assessment. Because it's not a patient level data set, it can only really be hypothesis generating. It is not a definitive statement around fact. And there's no cause of death that can be assessed or reported because it wasn't available to the authors. And no time to event analysis can be constructed, and I'm glad this talk comes after Sahil's, because you saw those graphs from the Sosembsky papers, and you see them fairly steady separation or commingling. You don't see them waving back and forth with different death rates, differences throughout. And that's typical of a time to event curve. You don't see movement in the curve in general. So because you couldn't see that in this representation of the data, it was limited in its interpretation. So there are multiple meta-analytic issues. I'm not a statistician, but I play one for purposes of these talks. There's a selection bias due to lack of complete trial inclusion. As I said before, and I'm just going to go to this, here's just look at the visuals on this. The bulk of the data, 28, 12, and 3. What you don't realize is that if you look at these 3 studies back here at 1 year, they actually show a difference in mortality with a paclitaxel signal at 1 year. So if you carry those same trial forward to 5 years and don't have any of the rest of them to balance it out, you will continue to see a signal. But because that represents a selection and therefore problematic, especially without that Kaplan-Meier curve that I showed you, would be important in that analysis. The meta-analytic issue number 2 is that the dose time product treats this, as I mentioned in my prior talk, as a radiation dose without any or with a very extended half-life. So the exposure is the dose times the balloon size times time, and time in this case is the time of follow-up. So if you had follow-up for 1 year, 2 years, 3 years, 5 years, that was the time variable that was inserted into that equation. That's a big deal. Pharmacologic dosing is not like that. It doesn't last 4 years. It's not radiation. It's not a particle that emits for forever. And there's a lot of problems with that. So the aforementioned bias of selection actually works against this. So what happens is you start selecting out the worst patient populations, those 3 studies that at 1 year showed a signal, now at 5 years show a signal, and they actually ended up having, according to the authors, more doses, and therefore they had worse outcomes. But they weren't balanced by other similar dosed devices. Note that the dosing for DES, specifically Zilver, was incorrectly assigned. Zilver is a stent, not a balloon, so the surface coverage is about 25%, not 100%. So the dosing has to be downregulated, and the authors actually knew that before they published, but they published anyway using that dose formula, and that's problematic at a minimum for a variety of reasons. The dose product is also problematic because any patient getting a paclitaxel device, the dosing will be different. And it will be different for a variety of reasons, even with the same device. Operator handling, how much they manipulate the device, the transit time through the sheath and into the vessel and how it interacts with the valve in that sheath. The inflation time and pressure may be variable by operator. The excipient efficiency will be different among the balloons. They're not the same and they don't transfer similarly. Crystallinity makes a difference into how well the device impregnates paclitaxel into tissue. Not everybody's tissue has the same avidity for paclitaxel. There are distal embolization rates which are quite variable, and the solubilization rates, which are a combination of multiple of the aforementioned bullet points, will be different as well. So this dose time product really becomes quite problematic quickly. And I'm going to just show the obvious here, which is that for all the pharmacokinetics we know about paclitaxel, all the known data for paclitaxel is that it follows a fairly standard pharmacokinetic curve, and by 6 months or so, or 3 months in tissue, it's not detectable. Note that these are in nanogram concentrations, which, as I mentioned before, is a billionth of a gram. So we're talking about very, very, very low doses of paclitaxel in tissue. To contrast that, paclitaxel dosing in breast cancer is quite remarkably different and bigger. There are multiple cycles totaling over a gram of paclitaxel versus single exposure of a few milligrams of paclitaxel. Now, granted, these are in cremophore solution. This is in a crystalline state. Nevertheless, the dosing is less than 1% of what we use in cancer. And it turns out that this strategy in cancer for patients with breast cancer is so safe that it's given to women who are pregnant, and there's no mortality or fetal abnormalities noted in the babies born to those women. So the meta-analytic issue number 4 is it's a numbers game. And all the data you've seen to date from Mahmoud, me, Sahil, and others, and Dirk are great. They're reassuring. They don't show any signal, but they're too small to really show a signal or to demonstrate a signal. So that's why a meta-analysis is relevant and important. It actually turns out that a well-done prospective study would require somewhere between 2,000 and 6,000 patients to show a mortality difference in the population of patients that are studied in these trials, because the rates of mortality are relatively low. They're not like the Medicare data set that Sahil showed you. They're in the single-digit percentages even at 5 years. So we have to have a pretty big number. So let's see if the data actually fulfill that requirement. You see here, and I think you've seen various forms of this, that if you look at the various device trials which are controlled with good follow-up, let's just focus on the PTA arm. It ranges from less than 1% in the impact SFA to over 12% in Levant-1. That's at 1 year data, or 2 year data, all-cause deaths. So you can see there's quite a variability, and that's just a statistical anomaly because you're dealing with relatively small numbers. This is the curse of small numbers. Okay, what about Katsanos' analysis? Well, at 1 year and at 2 years, there's enough patients to make a statement about, initially and at 1 year, there's enough patients to make a statement with robust statistics. But at 3 years, or 2 years and 5 years, the numbers trail off importantly because remember, we now only have 12 and 3 of the original 28 trials. And by the time you get to 5 years, the numbers are not big enough to avoid a type 1 error, that is finding a relationship that does not exist. The loss to follow-up withdrawals are not completely accounted for, or they are inaccurately accounted for. Frankly, the math in the paper is inaccurate. When I was assigned this talk, I took the paper home with a red marker, and I had to go out and buy another red marker before I finished. It's really a problem, and it should never have been published in this format. It's a problem with the editorial process, quite honestly. I'm not going to go through all these, but trust me, when you actually do the math, this is the numbers you get. Instead of 1.7, you get 1.2 for Zilver PTX, and this is without the crossovers. You get 1.5 rather than 2.1. And for impact, and John's probably already done this, you get a much different number. And when you add them all up and you do them correctly, you actually see that the differences cross unity, the confidence intervals cross unity, and you don't get a difference anymore at 5 years. So the next issue, and I think the one that probably will damn this paper the most, is that the PTA group is not paclitaxel naive for the entirety of the analysis. The data that was presented by Mahmoud and Michael's analysis of the programmed crossover of Zilver of about 25% in that first year is probably duplicated in all the trials that you've seen play out. If you have a 25% crossover in the first year or two, then those patients who are counted as paclitaxel naive in the PTA group are actually not naive. They're exposed to paclitaxel and need to move over into that arm. Well, if that's true, you're now moving over the non-death patients into the death arm. You're going to dilute the deaths. It all kind of regresses to the mean. I suspect when those data are available to us, and many of those data are being gathered and will be available in short order, you're going to see that there's not going to be a difference. A lot of this will blow up pretty quickly. I'm not going to go through this, but just trust me that all the trials done in the U.S. had paclitaxel available to them at the time of the trial. So I'm just going to walk through that. So in summary, paclitaxel pharmacokinetics and toxicity are well studied and characterized. There are no prior data that very, very low levels of drug are present as part of DCB and DES and use produce a mortality effect years later. In order to claim otherwise, and therefore be describing a very novel, grave, and significant paclitaxel toxicity, one would need to present level 1 evidence, prospective, randomized, and appropriately sized. A non-patient level meta-analysis, such as Katsanos, with multiple flaws, I believe many of them fatal, does not suffice to change my mind or my practice. Based on the analysis, it's impossible for me to know whether paclitaxel affects mortality. In order for at least me to understand that and think for all of us to recognize that without a lot of artifact, we will need large numbers, low loss to follow-up, complete accounting for all crossovers, and a more appropriate assessment of any dosing relationship that might exist. Thank you very much.